Now, moving on to our next presentation, it is our honor to welcome Dr. Venugopal, Executive Director and Chief IVF Specialist at ARMC IVF Fertility Center, Thrissur and Palakkad, on the topic New Facts in Fibroids, Endometriosis in Infertility and ART. A warm welcome, Doctor. Over to you.
Thank you very much. First of all, congratulations on the successful holding of advances once again. Respected chairpersons, seniors, friends and colleagues in the audience, very good morning to all of you. The topic given for today was about, it's rather extensive topic, endometriosis fibroids. I got a few slides. I had a little bit difficulty cluttering because there's so much of information to put it all into a piece of a talk for around 20 minutes is a little bit of a task. So I just, will go through a few of my slides and then I'll focus on areas which are relatively new. As we all know, one of the biggest challenges in endometriosis has always been diagnosis. A lot of cases of endometriosis are having difficulties in getting the diagnosis right. So what's new on the pipeline has come now, and in a couple of years, this will be very commonplace, is the use for salivary tests like this already available abroad based on the principle of microRNAs or miRNAs, that just small non-coding RNAs, certain miRNAs are differentially expressed. So, there's some of them are upregulated, some of them are downregulated. So, in the next, or maybe in the year itself, I'm told it's in the pipeline and this will come to India also. So, miRNA for early detection and diagnosis for endometriosis very much on the pipeline. Similarly, regarding imaging, now we traditionally rely on ultrasound, but then there is elastography that's coming up in a big way. Asha madam mentioned it her talk on adenomyosis also. The tissue stiffness which is there and the extent of fibrosis detected, and combination of CT with PET positive emission tomography. This is also coming up regarding location of endometriosis. So of course PET CT will expose a little bit to radiations, but fibrotic deep infiltrating lesions, these are increasing in endometriosis. Many times we detect them only on surgery, but this MRE, this elastography and this PET CT eventually will come and will be part of integral part of diagnostics. Next debate always is the real place of surgery for infertile patients with endometriosis. Always this question that in laparoscopy you found these areas of endometriosis, should you take them off, should you excise them, what is the thought process about it? There is a lot of research going on into the role of implants. So when you see implants like this, they are one of the important in the pathophysiology of endometriosis, and these implants have to be dealt with. You can do cauterization or you could choose to do, because they have a lot of roles, other than the physical appearance, altered macrophage function, contribute to oxidative stress, so overall contributing to the microenvironment. So, so you should deal with them, either excise them or ablate them. Those who do extensive endometriotic surgeries, I have seen even the other day, somebody had posted that a small implant was not dealt with and subsequently, it caused obstruction of the ureter and hydroureter hydronephrosis. So implants need to be dealt with. If you can excise it, that's very good, it's complete, it's technically challenging, but at least an ablation is desired. So this is very important. Similarly, now we have a lot of these young patients, who want to conceive at a later date. They have not decided to marry or anything, but you get a chance or incidental finding of endometriosis. So in our mind is always this question that whether it's observation that's good or medical suppression that's to be given, or what to do with these patients, because childbearing is not, they are not much symptomatic, but you have seen an endometrioma. So you should have this principle that observation is the preferred approach. Medical suppression plus or minus could or could not, you may or may not give, but you have to keep it in mind. And then they have other options. People ask you about these questions. Very latest, oocyte cryopreservation for endometriosis. It's a very attractive option. Patients ask that, I've got endometriosis, doctor, you're telling me it may progress to an advanced disease. Should I cryopreserve my embryos? You can counsel the patients that cryopreservation is an attractive option, but the number needed to treat, I highlighted on the slide on top, is 16. That is, if you cryopreserve the eggs of 16 patients with endometriosis, it's likely that only one of them is likely to end up going to have a baby. So the option is there, we need to have it, but proper counseling is essential, because when you try and freeze the eggs, you should realize that it's not magic. You froze the egg, of a lady does not mean that she is guaranteed to have a baby. This point should be very stressed and told to all the patients. Again, this patient with severe endometriosis, ovarian endometriomas, should you remove the endometriomas? Should you deal with the endometriomas? I want to tell you that there is a lot of talk going on. We are very concerned about the AMH and whether we should operate on these endometriomas. Those concerns are valid, but one point that has come back in picture is this thing called ethanol sclerotherapy. There are many people now who drain the endometriomas and then either needle guided or catheter guided, you put ethanol, 96% ethanol into the ovaries, and that has come. So, this thought that the presence of an endometrioma is a hindrance is coming back, and this ethanol sclerotherapy and things like that are coming. There's always this diagnosis that, first you should do IVF or first you should do surgery. There's an always pro and con debate that goes regarding this matter, and that debate is always there. Now the next is, if you are, we have to be in reality with the times, and then what happens is that many of the patients with low AMH, they are having low AMH, but they don't want to do IVF. So the question is what to do regarding these patients. So, there are a lot of studies for these patients that against the stream, we advise that endometriosis, let's not do surgery. But in deep infiltrating endometriosis and severe anatomy distorting endometriosis, there are a lot of articles that are coming up that, surgery might actually be of help for these patients, whether it's severe anatomical distortion, low AMH. Still, AMH is important, but this question addressed in a very latest paper in fertility sterility, whether pre-operative AMH, will it influence that if a patient undergoes surgery, if the AMH level is low, then does it mean that, you should not do surgery at all? That's not true. Okay. So, in stage 3, stage 4 severe endometriosis, it's not only about AMH. Okay, so surgical management of severe endometriosis in young women even with low reserve appears to be followed by good fertility outcomes. So never say never, like severe endometriosis, I'll never do surgery. I think that thought and concept is being revisited. But only thing, the surgeon should be competent enough and the surgery should be done in a manner respecting the anatomy. Similarly, now there's so much IVF going on. You have a lot of patients who have done IVF attempts, 2 attempts, 3 attempts, 4 attempts, and they've not conceived. Then what do you do with those patients? You can't tell them that no, you won't have a child. What about your fertility outcomes of these patients who failed IVF? This another paper I pulled out from fertility sterility. What happens is all patients had failed IVF, but after surgical treatment 33 women delivered and 3 women conceived spontaneously after IVF. So point I'm trying to make is that we've been grilled whenever we go for meetings, endometriosis, no surgery. No, I think we need to revisit that and individualize, and especially this surgery does have a role. That's why I put it into the slide, that it's a thought process that's being evolving over the thing. Another thing in endometriosis always we think is there a real place for medical management? In today's, this thing is very essential in today's discussion, that should we do? We have a lot of patients, because see, ultimately what is endometriosis? It's estrogen dependent, progesterone resistant, angiogenic and inflammatory. So why not try medicines that, are acting against on all these parameters? So many couples are there, they have bilateral endometriosis, they've been given months of oral contraceptive, then Dynogest, all patients desiring fertility. So is there a role for medicines in a patient desiring fertility? You should understand that a patient desiring fertility, there is no role for medication. This is very important. That concept hasn't changed. But there are some medicines that may be required. For example, your GnRH agonists, they have a role before IVF. This is important, that you could consider in these patients, GnRH agonists, IVF patients. Similarly, your Dynogest. In Kerala, we have patients, they have endometriosis. Then the husband would be going away for 2 to 3 years. You don't want disease progression. So I might think of a medicine like Dynogest. There are emerging medical therapeutics, what is the emerging strategies are very surprising. Microbiome modulation, this is one of the emerging strategies in endometriosis. They say that there's a role between the microbiome and then endometriosis. Similarly, you have Asha madam mentioned about it, this elagolix, raleogolix. See, all these are hogged by the representatives. We must remember they have been all investigated for pain related to endometriosis. They have not yet come into infertility as such. So pain of endometriosis, those sort of therapeutics are being explored. Then the next point that we need to think about is real place of assisted or IVF in endometriosis. I am an IVF specialist. IUI for mild to moderate endometriosis, but otherwise if required I will be going ahead for IVF. This is very important, and IVF does not increase the risk of endometriosis, and endometriosis does not have a negative impact on IVF success rates. So that those points are very important in endometriosis. So those are the few points that I wish to suggest, what's new and changing regarding endometriosis. Now we move with regard to fibroid. So when I was reading and for this talk about fibroid, there's a beautiful article again, Fertility Sterility by Jacques Donnes, 2024 Fertility Sterility. Again, mechanisms and management, what has changed. What is new in the pathophysiology of fibroids? This is very important to understand. Few things that, the pathophysiology has changed. Patients ask why I get fibroids. There are few concepts we need to know, that this concept of COMT in fibroids, then, transforming growth factor beta in uterine fibroids. These are new concepts that are emerging. Why we need to familiarize ourselves with new concepts is because the therapeutics will emerge from the etiological concepts. So, this thought that there's a chronic inflammation, then transformation, growth factors involved, all these are new concepts. What about the place of surgery for infertile patients with fibroids? Another question that's always being asked, when do we surgery? When there's cavity distortion, when we feel that there's impaired receptivity, there's contract, that's when we proceed with surgery. So definitely, we all know this, that, how do fibroids cause infertility? There's impaired implantation, vascular changes, greater distances for sperm to travel. So definitely, when we have submucosal myomas, we will do a hysteroscopy myomectomy. There's no doubt about it. So, and similarly, the question arises not for submucous myomas, question arises for the myomas that are there in the myometrium, away from the endometrial-myometrial junction. So there it's very important that what we should do regarding, see the type 0 fibroid, there's no doubt it has to be removed. The type 1 fibroid, there's no doubt. Even the type 2. Questions are asked about the type 3 fibroids, what to do. What we do is, that there is no doubt that, the submucous fibroid be removed. But then there is a lot of thought process that the endometrial gene expression is altered by the mere presence of a fibroid in the myometrium. So, we who practice IVF, even if it's a type 3 fibroid, if it's bigger than 3 centimeters, 4 centimeters, I am in favor of removing those type of fibroids. How to remove the fibroids? Should we remove it by laparoscopy? Or should we remove it by, that's a separate question. That depends upon the skill of the operating surgeon. But fibroids in general, if they cause problem with implantation, they should be removed, except for the subserous, sessile, pedunculated, those type of fibroids. What about medical management and new molecules for medical management of fibroids? So that is two groups of medicines. One is GnRH antagonists. Again, you'll find oral GnRH antagonists coming up everywhere. Your elagolix, relugolix, it's in India you have only elagolix, but abroad you have a lot of these molecules with add-back therapy. Now a lot of studies going on with these are all studies I put together. There's relugolix, there's a study called Reduce 1 and 2. With elagolix there are Liberty trials, and with linsagolix. So these are all exploring the role of GnRH antagonists, oral ones, in fibroid management. And they are approved in some countries, like relugolix approved by the US FDA, elagolix approved for heavy menstrual bleeding, linsagolix. So these are names we should, because the technology spreads fast. So in the next couple of months we can expect all these molecules to be available to us also in India at so where do we use it? Pre-surgical treatment, pre-IVF treatment, and an alternative surgery. So these are all molecules that are in the pipeline. Similarly, we know these two, mifepristone and ulipristal. Now, this is another group of molecules, came with a big promise, but because of the effect on liver function, there's small halt. But these are all good molecules. They're known to reduce the size of the fibroid. See, I put a comparison of mifepristone and ulipristal, and then you find that all of them, may, but role in infertility is where the question starts, may help in infertility or may not help. But some of them, they suppress ovulation. For example, ulipristal suppresses ovulation at therapeutic doses, and mifepristone at higher doses. So, you have to be balanced as to where these medicines are to be prescribed. Another question that always asked is, what is the place for uterine artery embolization in infertile patients with fibroid? That's an also a very relevant question that we need to address, because we find a lot of people who hawk these kind of treatments. There's a very good systematic review article on the pregnancy rate and outcomes after uterine embolization. It's a systematic review and meta-analysis with sequential analysis, very good, and it just says that the embolization treatment was associated with lower post-operative pregnancy rate and increased risk of postpartum hemorrhage. So, there are a lot of people who argue in favor of uterine artery embolization, nothing happens and this thing, but then it's a debatable thing, and then the meta-analysis shows that it might not be the best, and you should have concerns when your patient goes for embolization. The concern is regarding the impact on ovarian reserve. It's very, very important, that inadvertent embolization of ovarian branches can cause ovarian reserve, uterine endometrial myometrial changes, and definitely pregnancy related complications, miscarriage, abnormal placentation. Abnormal placentation is one of the areas of major concern. IUGR and preterm delivery have been reported. So what are the recommendations? I put a lot on this slide because it is a topic that is in for widespread discussion now. So your HRA and ARSM does not recommend it as first line treatment. Your Royal College also selected cases where surgery is contraindicated, but patient be counseled about fertility risks. Though the Society of Interventional Radiology recognizes it as an option for symptomatic fibroids, very good for decreasing bleeding, but still not an option for fertility. Then what about new algorithms in fibroid management? See, there are a lot of algorithms established for standardization of practice. So in fibroid also new algorithms are coming up. I picked this one up from one of the latest issues of Fertility Sterility, and you definitely find that medicines are creeping up into the algorithm. See, previously, especially in infertility, the medicines were not part of standard algorithms. But if you see this algorithm now, that you are finding GnRH antagonists slowly creeping up into algorithms. So this article written by Jacques Donnes, who is one of the reputed persons in fertility, you find that everywhere there is this scope of medical therapy for these myomas that is creeping up. So gradually that might be one of the thought processes, because there is a process thought against myomectomy as such, especially the laparoscopic myomectomy, because they say that it does a lot of damage inadvertently. So the new algorithms are slowly incorporating medical management and medical therapeutics for fibroids. So these are the things, depending upon the response to therapy, remaining myoma size and patient age, then women be guided towards natural conception or surgical therapy. So these are some, I just tried to highlight some of the new developments and some of the changing thoughts in the management of endometriosis and in fibroids. I did hurry up a little bit the presentation, but a lot of material, but I hope that in that little bit of time I was able to highlight a few points at least which will help you in your practice. So thank you very much for the opportunity.
Thank you so much, Doctor.
And thank you for a patient hearing.
Thank you so much, Doctor. We kindly request you to please stay back onto the stage.